welcome to Medical Dialogues, your daily dose of health and medical news. I'm Isra Zaman and today I'll be discussing about asthma and its mimics. Asthma is a chronic respiratory condition affecting the lungs and respiratory airways. The total burden of asthma in India stands at 34.3 million, accounting for around 13% of the global burden. General symptoms of asthma include shortness of breath, chest pain and cough. However, this disease can be difficult to diagnose because there are many conditions that can cause asthma-like symptoms, especially in young children. So to talk to us in detail about the condition, we have here with us today Dr. Aditya Jindal, who is a pulmonologist with 10 years of experience currently practicing at Jindal Chest Clinic, Chandigarh. We welcome you to Medical Dialogue, sir.
Thank you.
So if you could tell us, what is asthma and what are some common conditions that mimic asthma?
Yeah, so asthma is a disease of the airways in which there is a reversible and variable obstruction of the airways. So technically speaking, or putting it in simple language, it means that the airways in our lungs get narrowed, and but they do so at variable intervals, and this can happen at any time of the day and or any part of the year, and this is reversible. So essentially, this reversibility and this variability is a characteristic of asthma, and some of the other common mimics of asthma are, of course, COPD or chronic obstructive pulmonary disease, which is a disease in persons caused mainly by smoking, either active or passive smoking, or by environmental pollution or indoor air pollution, especially among women in our country. And this is one of the most common mimics of asthma. I think the only way to differentiate it perfectly or with some degree of certainty is by establishing that there is no reversibility or variability in COPD as there is in asthma. So this is generally done by a pulmonary function test or a spirometry. There are, of course, other quite common mimics of asthma, and some of these are not exactly mimics. You may call them in diseases in which asthma is sort of a part of the disease presentation. Looking at age-wise stratification, the common differential diagnosis of asthma in young children would be inhaled foreign bodies, especially which can present with breathlessness and wheeze, bronchitis, bronchiolitis. In the elderly, again, presence of or in the adult population, COPD in smokers or in indoor air pollution exposed persons, like I've already mentioned. Additionally, foreign bodies are less common in adults as compared to children, but endobronchial tumors or tracheobronchomalacia are among the sort of mimickers of asthma. As to the other diseases in which asthma is a presentation rather than an exactly mimic, I would say there are other conditions like allergic bronchopulmonary aspergillosis, in which patients generally present with asthma-like features, and on investigation they are found to have this disease. It's also called as ABPA in short. Then some types of vasculitis of connective tissue disorders may present with asthma-like features, especially eosinophilic granulomatosis with cholangitis, also called as Church-Strauss syndrome in the past. Then parasitic infections, Loeffler syndromes, and tropical pulmonary eosinophilia. All these are sort of diseases in which asthma is part of the sort of the presentation. Now, there is another category of diseases in which there are some common symptoms, but anybody who has some sort of adequate clinical knowledge, who will take the history and examination, will be able to differentiate easily. And some of these diseases are interstitial lung diseases in which there is lung shrinkage. This can be commonly differentiated. This can be easily sort of differentiated from asthma by the history and the chronicity. And of course, bronchogenic carcinoma and other type of lung tumors, pleural effusions, in which the common presentation is breathlessness. Yeah, but I think the main differentiating point in diagnosing asthma will be establishing the reversibility and the variability in the airway obstruction.
That was very insightful, sir. Now, what are the most common symptoms of asthma?
Yes. The common symptoms of asthma, so asthma is mainly limited to the lungs. It's not a systemic disease as some of the other respiratory diseases are. So the common symptoms of asthma vary according to the age. In younger children, I'll just tell the classical symptoms of asthma first, which are breathlessness, especially early morning breathlessness, and so people have a feeling of chest tightness or suffocation, especially while waking up in the morning, or they are woken up from sleep in the early morning, and this breathlessness will worsen with exertion. Then there is wheezing, which is has been associated with asthma for quite some time. So it's basically a whistling sort of noise produced by the narrowed airways in the lung. These are more common during the early morning hours as compared to the rest of the day, but can occur at any time. Dry cough, usually productive cough, that is cough with expectoration, is not that common in asthma. However, it may be a part of the presentation in ABPA, that is the allergic bronchopulmonary aspergillosis. But as such, in pure asthma, generally patients have a dry cough or may have some small amounts of expectoration. Other symptoms like fever, chest pain are less common or not part of the sort of standard presentation of asthma. In children, asthma may present a bit differently. It may present basically as a dry cough only without any breathlessness, along with failure to thrive, growth retardation, and maybe some wheezing or some nocturnal symptoms. That's about it. Yeah.
All right. So, how do we differentiate asthma from its mimics and diagnose this disease?
Yes, so we need to have a high index of suspicion whenever we come across a case which is sort of presenting as asthma. The clinical history is of crucial importance in diagnosing any sort of respiratory disease. The examination as such has limited role, especially in the current scenario. But anyways, the history is much more important. The chronicity of the history, the sort of the variability in the symptoms, how the disease has progressed over time, those kind of and the triggering factors, all those things which one typically takes in the history are much more important in the diagnosis of asthma and its differentiation from other diseases. Then the main test or the standard test to establish a diagnosis of asthma and to differentiate it from the its closest mimics like COPD would be the spirometry or the pulmonary function test with the bronchodilator reversibility test. So if the spirometry is showing some degree of obstructive airway disease, then a bronchodilator is given, and according to the set protocol, and the spirometry is repeated after some time. And if there is improvement in the airway obstruction, significant improvement in the airway obstruction, then one can make a confidently a diagnosis of asthma as compared to COPD. Of course, there are other laboratory-based investigations which can be done, which are not used in clinical practice, such as the methacholine induction test, which generally should not be done. So, practically speaking, spirometry is the main method of diagnosis. Forced oscillation techniques, again, for younger children and for elderly people who are unable to do the forced maneuvers required for spirometry, are also useful and can be used to make a diagnosis of asthma. However, they have not been fully standardized as is in the case of spirometry. Other investigations are mainly for ruling out other causes or other mimics, for example, the chest X-ray, maybe some blood investigations, especially ruling out ABPA by doing the ABPA panels or the IG levels, in specific scenarios, ruling out any vasculitis or other things. And if there is a high suspicion of bronchiectasis, maybe doing a CT scan to see whether there is any bronchiectasis or not. Yeah, but the two basic things would be taking a detailed clinical history and doing a pulmonary function test with bronchodilator reversibility.
Okay, so what are the pharmacological and non pharmacological approaches to treat asthma?
Yes, so the pharmacological approach to the treatment of asthma is basically based on inhaled steroid use, and inhaled steroid use in the form of inhalers, either beta dose inhalers or dry powder inhalers. Now, usually we do not use the inhaled steroids on their own, but they are used in combination with inhaled beta 2 agonists, which act as the bronchodilators, while the steroids are anti-inflammatory agents, and they reduce the airway inflammation, which is the sort of the cause behind the symptoms in asthma. The use of inhaled corticosteroids will reduce the inflammation and later on lead to sort of control of that episode or attack of asthma. Use of bronchodilators alone does not really will relieve the initial symptoms, but will not lead to a control in the attack, and we'll never be able to stop the inhalers in that sense. So generally, a combination of inhaled corticosteroids and beta 2 agonists is used, and depending on the severity of the episode, anywhere from 1 month to 3 months course might be needed. In severe cases or difficult cases, one might give a short burst of or short course of oral corticosteroids also, and sometimes we need to add long-acting muscarinic agents, those kind of inhalers also. Uh, Use of theophylline has been very popular in the past, but now they are only recommended as just as an add-on therapy in patients who are difficult to control asthma rather than as the upfront treatment because of their toxicity and side effect profile. The best combination, best use sort of treatment would be the inhaler therapy, especially combination of inhaled corticosteroid and beta 2 agonist. For difficult asthma or severe asthma, which is not responding to the usual treatments, new biological agents are used, and some of these include omalizumab, mepolizumab, benralizumab, etc. There are other chronic azithromycin therapy, bronchial thermoplasty procedures like that also there. Among the non-pharmacological treatments of asthma would be, I think, main would be trying to identify the cause or the triggering factor for the asthma symptoms and trying to avoid those things, especially, for example, doing dusting in the house or avoiding polluted areas or maybe avoiding some areas where there is a lot of organic dust in the area, especially like you say, farmyards or especially the harvesting season in North India or maybe in other parts of the country. Even sometimes pollination from large scale pollination over a wide area from trees or plants also is a lot of pollen spread in the air can also cause attacks, that's especially known in the Himalayas in some areas. So the best thing would be to avoid these areas. Second is to maintain a good general health overall. Don't avoid exercise. Try to maintain good physical routine. But especially don't start exercise during the attack of asthma. Get controlled and then maintain a good level of sort of health. Have a good diet. Don't become obese because obesity, any sort of obesity, will precipitate the asthma and lead to difficulty in the control. And of course, in some advanced cases, pulmonary rehabilitation in the form of rehabilitative exercises, physiotherapy, etc., might help.
Thank you for your valuable insights, Doctor.
You're welcome. Thank you.
That's all for today. Stay tuned to Medical Dialogues for latest updates.